Okay, good evening everyone. So today also we are going to continue the same type of discussion, and I hope these are very useful for you in your future career, or even during the this one, what is that called, graduation exam. Okay, if it happens, I'm sure we will conduct it in some day, and maybe in your own board exam in the respective country. Okay, so let's continue. Please have a look at case number 1 and we'll move further. Yes, anyone?
Yes, sir.
Yes,
Sir,
Hemant.
I will go with Marcus Gun Pupil.
Okay, can you explain?
Yes, sir. Sir, in Marcus Gun Pupil, each pupil respond different when light is shown into them.
Mm-hmm. Good.
Yes, sir.
Okay, good. Okay, then uh, any other student? This is a very easy one. He's absolutely correct. This is the Marcus gun pupil, also known as relative efferent pupillary defect. Now see there, a 30-year-old lady has a normal pupillary size and observation, but on shining the light into each eye in turn, this is important clue, the left pupil dilate rather than constrict. This is Marcus gun pupil. This is how we do the test. But for your information, let me quickly talk something about the other options as well. Horner syndrome, it has got 4 components. One is meiosis, second anhidrosis, third inophthalmos, and 4 ptosis. Okay, so nothing like that here. So this is easy to exclude. Third nerve palsy or oculomotor nerve disease, we have again the problem in the pupil. Third nerve usually constricts the pupil. So if third nerve is damaged, there is dilated pupil. Then there is a ptosis as well. So many other extraocular muscles are also paralyzed. Eddy's pupil. Okay, Eddy's pupil means it is a dilated pupil, isn't it? Some postganglionic parasympathetic nerves are damaged. So this is Eddy's pupil, completely different situation. Opioid overdose. There is bilateral pinpoint size pupil on both sides, and there is no such history like that. Argyll-Robertson pupil means the light reflex is absent, but accommodation reflex is present, and it is one of the feature of neurosyphilis. So this is called Marcus gun pupil. Now, what may be the cause of Marcus gun pupil? Can you give me just one cause? Any cause you know?
Yes, sir.
Like
Yes,
what?
sir. Sir, disease of optic nerve or retina, sir.
Very good, excellent. Yes, disease of optic nerve or retina can give rise to Marcus gun pupil. So see this, This woman has a relative efferent pupillary defect or a Marcus gun pupil. Unlike most other pupillary abnormality, the pupil are normal on observation. Normal on observation. Let me, yes. However, the swinging flashlight test reveals a paradoxical dilation of the pupil on shining the light into the eye with the abnormal optic nerve. This is the cause here, this abnormal optic nerve or optic neuritis. Let's move on. Let's go to the number 2. Okay, any student?
Option B, sir.
Yes, Derek, it's option B. Okay, can you explain this to me?
Dermatomyositis.
Okay, why?
When we look at history, she has difficulty in rising from a chair and proximal weakness. So this suggests more of a myopathy than a neuropathy. And also the red parts on her back of her fingers, that's also one of the classical features.
So what is the name of that classical feature?
I've forgotten the name, sir.
No problem, but the way you have explained is absolutely right. Okay, so let me take over now. This is a 40-year-old lady who develops difficulty in rising from a chair and has proximal weakness in her leg. Now they have already given, if somebody has a difficulty in rising from a chair or even standing, from a sitting position, that means there is a proximal myopathy. Proximal myopathy. And proximal involvement of the muscle is not a feature of nerve involvement usually. This is a myopathic disease. Now this is a very important clue for you. Okay. She is also noted to have a red area over the back of her finger. Now if you have studied dermatomyositis somewhere, okay, then you must have remembered this finding. This is called Gottron's papule. Gottron's papule. This is one of the pathognomonic feature of dermatomyositis. One more feature I like to tell you here, just over the upper eyelid, okay, there is some rashes present in dermatomyositis. That is called heliotrope rash. So these three things, proximal myopathy, Gotron papule, and heliotrope rash, are highly typical of dermatomyositis. Now, this doesn't look like multiple sclerosis at all. No such features have been given. Okay. Common peroneal nerve palsy. Anybody can tell me what is a feature of common peroneal nerve palsy? What will happen to the patient? What will happen? What is a typical clinical feature of common peroneal nerve palsy? This is called foot drop. Okay, foot drop, because a foot cannot be dorsiflex if common peroneal nerve is damaged. That is called foot drop. Don't forget it. All those tibialis anterior muscle, the muscles of anterior compartment of the leg are gone. They are paralyzed. Now L5 disc prolapse. It doesn't look like that. L5 and S1, they usually supply ankle jerk area. Diabetic amyotrophy, there is no history at all. And myasthenia gravis, it doesn't look like that. Okay, so straightforward case. So this answer is B. This woman has a proximal myopathy with a rash on the back of her hand, which is consistent with Gotron's papule. This is a feature of dermatomyositis. This is a type of connective tissue disorder. Let's move on. Okay, let's see number 3 now. Okay, anybody has come to the conclusion, a diagnosis here?
Option E, sir.
Option E. You mean Brown-Sequard syndrome?
Yes, sir.
Okay, explain, please give explanation so that everybody can hear you.
So Brown Sequard syndrome is also called like the hemidissection of the spinal cord, in which like there is impaired proprioception and vibration of his left leg. So it means that there is the damage to the dorsal column tract, while impaired pain sensation, and there will be also impaired temperature sensation on the right leg, which means there is spinothalamic tract involved, which cross to the contralateral side at the level of spinal cord, while dorsal column tract cross to the contralateral side at the level of medulla oblongata.
Very good. So this is Brown-Sequard syndrome. He has explained almost everything there, okay, in an excellent way. Very good. So this is a little bit difficult case, but you pick the right points. It is not that difficult. This is the beauty of neurology. Let me explain here. This is a 46-year-old man presents with weakness of his left leg. So there is definite weakness. So there is motor involvement. An examination of his sensation, he has impaired proprioception and vibration in the left leg. That means the same leg which is paralyzed. The impaired proprioception and vibration also occurred on the same leg or same side. And there is impaired pain sensation in the right leg now. The opposite leg has lost the pain sensation. So clearly paralysis and impaired proprioception and vibration occur on left side and impaired pain sensation occurred on the right side. Okay, so if you go to the detail of those ascending and descending tract and those sensory fibers, dorsal column tract fiber, they do not cross at spinal level. Is absolutely right. They go up higher up in the medulla and they only cross and go to the opposite side. Whereas the fibers which carry pain, touch and temperature, which are called spinothalamic fiber, they cross right there, okay, at that level which we are talking, and go to the opposite side. So if a disease which causes hemisection of the spinal cord on the left side, okay, on the left side in this case, this will cause paralysis on the same side, because now the corticospinal fiber, they don't cross, they have already crossed way up in the medulla. So paralysis occur on the same left side, as well as dorsal column tract weakness or sensation loss also occur on the same side, whereas the spinothalamic tract sensation loss occur on the opposite side. So this is hemisection of the spinal cord, and it is also known as Brown-Sequard syndrome. So E is the answer here. This is the way you need to reach to the diagnosis. So this discussion actually, I have arranged not only to reach the diagnosis, not like that, okay? Please listen the reason and try to learn something here. Now, there is one new term for you probably, which is called Charcot-Marie tooth disease. Anybody can tell me what is that condition? Anyone? Have you heard this term before?
Sir, it is like a herniation of the cerebellum.
Are you sure? Okay. Any other? Wait,
Mm,
I want to hear some more answer. Anybody else?
Sir, it affects peripheral nerves, sir. It's a genetic condition.
Okay.
Yes, sir. And it causes the motor and sensory nerves to become damaged, and then after that it dies, sir.
Okay.
And it leads to weakness and wasting of the muscle below the knees, sir. Below
Okay.
knees, it. Yes, sir.
Fine. So he's right. Actually, the many of the feature he has explained properly. Remember, this Charcot-Marie tooth disease is a hereditary condition. It runs, okay, in the family, hereditary condition of peripheral neuropathy. Hereditary peripheral neuropathy. Just remember these two terms. Now we can write everything after that. Some muscles are affected, okay, some sensations are affected, and one very important point which occurs here, okay, is called pes cavus. Pes cavus. That means if we examine the foot of these people who are having Charcot-Marie-Tooth disease, you know, there is a cave-like appearance, okay, like the anterior part of the foot and the heel, okay, they are touching the ground, but the middle part of the foot is way higher, just like a cave. So this is called pes cavus. If you remember this, hereditary neuropathy and pes cavus formation, then you can handle any question which they ask from the Charcot-Marie-Tooth disease. Okay, let's move to the another case. Now let me show you the answer, because you know I'm recording a video here. The answer is E. This man has the classical features of Brown-Sequard syndrome, which is also known as hemisection of the spinal cord, and it has a feature of dissociated sensory loss, that is dorsal column loss ipsilateral to the lesion and spinothalamic tract loss contralateral to the lesion. Don't forget, this type of questions is very favorite of the examiner. Let's go to case number 4.
हाँ दरवाजा इधर दी खत्म करवा के उधर लुकाऊं नहीं
Okay, anybody?
Option D, amidron.
Option D, amidron. Okay, you are right here, but can you tell me what has really happened to this patient? Can you explain?
Sir, amidron is a side effect like lung fibrosis.
Well, 1 minute. Can you tell Mohammad Asif to mute his microphone, please? No. Okay, I'll wait 1 second. Okay, I'll mute him. Yes. Okay, Ilyas, you go on.
Sir, most probably the patient has used the drug, and amidron have a very famous side effect, lung fibrosis.
Absolutely. You don't need any other explanation here. This is a very straightforward question. You see there, and it's very easy if you know the side effect of amiodarone. So let me explain you. One minute. Okay. Now she is a 59-year-old lady with grade 3 congestive cardiac failure. She already is in grade 3 congestive cardiac failure, means with a slight amount of exertion. Okay, she develops dyspnea and she has a lot of signs and symptoms of heart failure. Has become increasingly short of breath despite excellent control of her cardiac function and no deterioration in her ejection fraction on echo. So they have ruled out the problem from the heart side. A chest radiograph is reported to demonstrate bibasal lung fibrosis. It is clearly given. This lung fibrosis has happened recently, which was not present 2 years earlier. So it must probably caused by one of these medication. Atenolol doesn't cause lung fibrosis. Spironolactone doesn't cause. Digoxin doesn't have that type of effect. It has to be amiodarone from the list. Okay. Now, so let's talk a little bit about this lung fibrosis and the medication which are causing it. See here, pulmonary disease caused by medication is well recognized fact. Amiodarone is one of the important drugs which cause pulmonary fibrosis. This amiodarone belongs to class 3 antiarrhythmic drug. We all know that. Okay, class 3 antiarrhythmic drug. Never forget this very important point. It is usually used, okay, to treat arrhythmia case, but one of the important side effect is interstitial pneumonitis. Then after that, pulmonary fibrosis. Now at the same time, why I am showing this slide to you is sometimes the examiner may give you another drug there and ask a similar type of question. So which are the other drugs which cause pulmonary fibrosis, like busulfan, bleomycin, methysergide, and cyclophosphamide. Now, in the examination, we choose these two, busulfan and bleomycin, as the very important drug on the list. So don't forget them. Okay. So this is the messages which you get from the slide. Let's move on. Okay. Wait. Let me remove these lines first. Okay. Look at this case now. Now this case is from respiratory system. Okay, so it is difficult. Anybody ready?
Sir, most probably option D.
Option D.
D,
Okay, B or D? You mean
D,
D?
sir, option D. Yes,
D.
sir, 3.8 gram per
Uh,
deciliter.
and LDH, which
Sir, 294.
and pH is 7.45. Now, why you chose that? You must have some reason.
So, sir, this question is like they are asking about empyema. So, empyema is infection. So, the
Uh-huh.
fluid which is accumulated, it must be exudative in nature.
Okay.
So, exudative fluid are protein rich.
Hmm. Yes, that reason I accept. Okay. Wait. So I'll explain this a bit later. Okay. Anybody else? Any other guys? Yes. Okay. So let me explain. Nobody has any idea about it. So this is a case, okay, about plural collection. So you'll have a lot of idea about this type of cases after this. So this is a 45-year-old oil rig worker who is admitted with fever and shortness of breath following a return from a secondment overseas. Now, 4 days into his admission, he develops worsening symptom and a chest radiograph reveal a pleural collection. They have already given the diagnosis. A pleural tap is performed due to concern. This may represent an empyema. Now, the question is, which of the following results is most fitting with an empyema? Now, let's talk about empyema a little bit here. This is pus present in the pleural cavity. And in case of empyema, remember one very important point, the pH should be highly acidic. Okay, pH should be highly acidic. Usually that pH is less than 7.2. Okay, less than 7.2. This is one very important point. Another one, the protein level should be very high. Okay, protein level should be very high because this is even worse situation than exudate. There is a frank pus present in the pleural cavity. And another one, LDH level should be more than 200. When LDH is more than 200, then we call that exudate. Okay. Now, according to light criteria, there is one criteria known as light criteria to differentiate between transudate and exudate. Okay, there are so many different things. For example, ratio between the um, uh, protein of the pleural fluid versus protein in the serum. Okay, and all those things are there. So if I choose that, then option B will be the right answer. Option B. So we are talking about this case number 5. Okay, and they have already given the diagnosis, that is empyema, but we need to choose the correct option. Out of these, which investigation fits the diagnosis of empyema? And the answer is B. The protein is high here. Okay, this is gram. Okay, gram per deciliter. LDH 370. It should be more than 200 for the exudative confirmation, and pH is also very low, 7.15. Now, if I take any other combination, all those three things will not match there. Now let take this opportunity to explain about transudate, exudate, and certain things about empyema. Now see here. Okay, now the answer is B. Protein 3.8, LDH 370, and pH 7.15. Now we all know what is pleural effusion. It's a collection of free fluid in the pleural cavity. If that pleural effusion is infected, then there is high chance of conversion into the empyema. And pH is measured when there is concern regarding an empyema, and the pH in case of empyema is usually less than 7.2. So don't forget, from now onwards, this type of cases would be asked to you repeatedly. Okay, let's discuss something more here. Okay, now see that transudate have a protein content of less than 3 gram per deciliter and a lactate dehydrogenase concentration of less than 200. This is transudate. So this is how we confirm transudate. And causes of transudates are, any student can answer this: heart failure, hypoalbuminemia because of any nutritional or malnutrition we should say, or probably protein losing enteropathy. Renal failure, most important is nephrotic syndrome. Rather than failure, we should write renal diseases here. Liver diseases, okay, like cirrhosis of the liver and even constrictive pericarditis. All of these are the causes of transudative fluid collection. Now, what about exudate? They have a protein content of more than 3 gram per deciliter and LDS concentration of more than 200. This is a very, very important point you should remember from this discussion. See this, more than 200, that is LDH, and protein more than 3. Now, the common causes of exudate include lobar pneumonia, which are mainly caused by bacteria like pneumococci, cancer of the lung, mesothelioma is a pleural malignancy, pulmonary emboli, okay, tuberculosis, and empyema. And this is the case of empyema here. Okay, now let's go to the another case, number 6. Okay, anyone? This is a very easy case.
Sir, option is small or odd cell carcinoma.
Okay, Elias. Yeah. Why did you say that? Just give me a few reasons. Why not? It's not a case of squamous cell carcinoma or bronchoalveolar cell carcinoma. Why did you choose oat cell carcinoma? That's the question. You are right, actually. Okay, this is the correct diagnosis. Okay, so let me explain this. This type of cases are not that very difficult for you if you know certain points. So here is a 60-year-old pub landlord and lifelong smoker. So there is a long history of smoking, and this person is relatively old. He is admitted with lethargy and drowsiness. Lab tests reveal results consistent with SIADH, and a chest radiograph demonstrate a 3 centimeter right upper lobe mass. He is due to undergo a CT-guided biopsy of the mass. What is the histological subtype most likely to be? Now, if you are clever enough, okay, now look at the options here. Most of the options are malignancy, except hematoma. This hematoma is not a malignancy. Okay, this is malformed tissue. But most of the others are malignancy. So this has to be one of the malignancy. This is the way, okay, we narrow our differential diagnosis. Now, if we go into the lung cancer topic, these paraneoplastic syndrome are very common with small cell carcinoma or oat cell carcinoma, except one paraneoplastic syndrome, which is called hypercalcemia because of PTH type of substance. All other are very commonly seen in oat cell or small cell carcinoma. Now, one important question that comes in your mind is why so? If we go into the detail of small cell or oat cell carcinoma, if we examine by electron microscope, they have certain granules inside them. Okay, those are called neuroendocrine granule, and they are the source of all these paraneoplastic syndrome. Okay, so this is small cell or oat cell carcinoma. So in the next question, they may give you another example of paraneoplastic syndrome, like Cushing syndrome, okay, something like that, or some other. So don't get confused. So you need to use your quick mind during that time. So this is small cell or oat cell carcinoma, and SIADH is one of the common presentation. Now number 7. Okay, anyone? This is no, not that very difficult question actually. This question is related about the workup before you do certain test. Some precaution maybe.
Sir,
Yes,
option A.
option A.
Yes, sir.
Okay, you want to go for normal liver function
Yes,
test? Yes. Anybody else? Yes, yes. Now I'll explain about this case, and you yourself know what is the likely diagnosis here. Okay, this is a 36-year-old woman who is admitted with shortness of breath and pleuritic chest pain and shortness of breath following a 16-hour flight to London from Borneo. Now she has been in flight for a long time. Okay, she's 36-year-old lady and she presented with shortness of breath and pleuritic chest pain. Now Borneo, if I'm not wrong, it is in Malaysia. Okay, Malaysia to London, a long 16-hour flight. Now during that time, what happens? Because of prolonged, sitting on one place, there is high chance of formation of deep vein thrombus. Somehow that deep vein thrombus may get detached and results in pulmonary emboli, and they want to rule it out. So the working clinical diagnosis is a pulmonary embolus, and a CT pulmonary angiogram is requested. So what is the most important consideration before the test can go ahead? Now remember, when you do this angiography, you need to inject certain dye inside the blood vessel, inside the vein, usually iodinated dye. And those iodinated dye can cause severe kidney toxicity if renal function test is not normal. So this is what they are trying to ask here. In a normal kidney function, nothing will happen. You don't need to worry. But who knows, isn't it? Maybe she is dehydrated. Maybe she has some other kidney diseases. Until and unless we do this type of baseline investigation, we are not sure how she is going to behave. Okay. Now see here. So this is the answer. Let me go through it now. So this the renal function test should be done. So this is a CT pulmonary angiography, which is a diagnostic test. Okay, we want to rule out whether pulmonary embolism is there or not. So when we do this, the radiological contrast material should be given, and they are nephrotoxic. So we need to make sure whether the kidney is in right condition or not. So there is one list which is given. Okay, the contrast nephropathy. Let me highlight this for you. The contrast nephropathy is amplified by the presence of coexisting condition in the patient, which include renal impairment, which is already present or not. Renal function test will tell us that. If urea and creatinine level are normal, probably there is no renal impairment. Hypovolemia, this is dehydration or low blood pressure, low cardiac output, diabetes, especially if treated with metformin. Okay, this is oral anti-diabetic drug, and hyperviscosity, which may occur in myeloma. So during this situation, we don't, do this type of test. Okay, let's go for number 8, and I am very sure this case can be handled by many students. Okay, let's check. Okay. Yes, Michael, what is the diagnosis from your side? Are you online? I can see his name there, but he's not answering. Okay, who can answer this?
Sir, option C, small cell carcinoma.
Okay, this is small cell carcinoma, but can you tell me which is this condition?
Sir, it is paraneoplastic syndrome, like ACTH is secreting, which is causing Cushing's syndrome.
Very good, excellent. Okay, this is the explanation. So no need to explain any further thing here. This is a 56-year-old chronic smoker who presents to his general practitioner with lethargy and a change in appearance like rounded face and striae, an increase in weight predominantly around the trunk and increased blood pressure. All of these are suggesting Cushing syndrome or Cushingoid appearance. Now, just a few cases ago, we discussed this. Okay, because of this chronic smoking history and a 56-year-old person with this may be a case of paraneoplastic syndrome. And the most common lung cancer which gives rise to paraneoplastic syndrome is small cell carcinoma or oat cell carcinoma. So this is Cushing syndrome caused by ACTH release by small cell carcinoma of the lung. This is the way you connect between the different logic. So small cell carcinoma, which is ACTH secreting. Okay, this is the answer. Now a little bit information here. This small cell carcinoma is highly associated with smoking, and it accounts for 20 to 30% of all lung cancer these days. Not the very common one, but one of the commonest. They arise from endocrine cells, explaining why polypeptide hormone are often secreted by these tumors. There are so many paraneoplastic syndrome. We can give example here. This Cushing syndrome because of ACTH. Okay. Another is SIADH. We have seen that case few cases ago, isn't it? These are the different examples. Now, number 9. Now this case is from GI system. The options are given in the next slide. So please go through these first. Okay, try to reach maybe certain diagnosis will come in your mind, then we'll go to the option. If somebody is planning for MRCP, USMLE, or PLAB type of exam, or even AMC, please remember this type of questions are the one which they ask. Okay, and still these days, like in any type, wherever you go, any board type of exam, these questions are very common. Yes, anybody has reached to the conclusion?
So primary
So
sclerosis.
they
Okay.
are mentioning hepatopathology
Uh-huh.
uh, and the results. So we will associate there is a condition in which ulcerative colitis present with many conditions, pyoderma gangrenosum, etc. But in this case, I will go for primary sclerosing cholangitis,
Okay.
association of ulcerative colitis with.
Okay. So what clues you got from the case?
I I got the clues of hepatopathology in the last lines, sir.
Okay.
Elevated bilirubin, elevated ALT, AST, everything.
Good. Good.
So correlate this with their primary sclerosing cholangitis in UC.
Very nice. Yes. So let me hear some other views also. Okay. Good. Good, Rahman. Yes, Ilyas, you want to say something?
So the diagnosis is same, and there are some other feature which also suggest of primary sclerosing cholangitis. There is itching and fatigue, which may suggest of post-hepatic jaundice, and the
Okay.
PNK is positive, and
Okay.
there is also history of ulcerative colitis.
Good.
The primary sclerosing cholangitis is well-known extra GI manifestation.
Now, both of them are absolutely correct. You know, the way they are explaining. See this case is such a long one, but if you can pick certain clues, the diagnosis will be easy. See that? I have not even shown the options and they have already diagnosed it. Now, let's go to the option first and then I'll come back and explain this. See here, which of the following is the most likely diagnosis? They have asked cholelithiasis, hepatocellular carcinoma, primary sclerosing cholangitis, viral cholangitis, and primary biliary cirrhosis. Now, let's go back to the case here and try to pick the important point. A 48-year-old man with a history of ulcerative colitis, clearly given. He is a patient of ulcerative colitis. He attends the gastroenterology clinic for his regular review. Over the past few months, his bowel symptoms have been well controlled, but he has suffered from itching and fatigue, some two other important problems. And the following blood test results are ascertained. This is WBC count or white cell count, normal, platelet count also normal. Now, autoantibody screen, see here, PNK positive, perinuclear antineutrophil cytoplasmic antibody, PNK is positive, antinuclear antibody is also positive, but antimitochondrial antibody is negative. Now, in primary biliary cirrhosis, antimitochondrial antibody would be positive. So, if this is negative, you can easily rule out the last option, primary biliary cirrhosis. Okay. Now let's go to the other investigation. Bilirubin is high. Okay, this is the normal value, less than 20. It is 65 here. ALT is also high. AST is also high. ALP, okay, is high, and GGT is also high. Now, if I analyze all these, liver is affected. There's no doubt about it. But which component? Okay, which component inside the liver is affected? Is it hepatocyte or is it biliary channel? Okay, which one? Which is more affected? What do you think? Is
Biliary
it
channel.
Biliary channel.
exactly? It's biliary channel, right? But hepatocytes are also affected. I'm not denying that. Otherwise, these ALT and AST are not higher. But look at ALP and GGT. So biliary tracts are more affected than hepatocytes. So this is typically happens in primary sclerosing cholangitis, where all those biliary channels would be affected, and it is strongly associated with P and Ka. So this is how you can reach to the diagnosis. Okay, let's see the explanation. Then we'll end today's discussion. Now see here. Okay, let's know few new things. Primary sclerosing cholangitis is a chronic liver disease which results from inflammation of the bile duct, and this is associated strongly with ulcerative colitis. Very good. Okay, You are picking it very correctly. The gamma glutamyl transpeptidase GGT and alkaline phosphatase levels are usually the most elevated of the liver enzyme, although rises in AST and ALT can also occur, and bilirubin in more advanced disease. Everything is here. The disease is believed to be autoimmune in nature, hence, see, autoimmune, hence both anti-nuclear antibody, that is ANA, and P&K may be positive. Primary biliary cirrhosis is another autoimmune liver disease where ANA may be positive, but more typically anti-mitochondrial antibodies are also present. But in this case, they are negative, so we don't think about a primary biliary cirrhosis. So this is the way we reach to the diagnosis. Okay. So let me stop here today. Thank you so much. Okay. We'll